Greetings from National Academy of Medical Sciences, India. Focusing on NAMS Vision 2030, NAMS is pleased to share some of the important activities like NAMS National, International Fellowship and Membership, Member After Day NBIM NAMS, NAMS Task Forces, AIIMS NAMS Navigate Medico CME, CME activities, publication of annals, newsletter, networking with professionals, public orations, Young Scientist Fellowship, Scientist Exchange Program, scientific visit of Emeritus Professor and many more activities. All application forms for fellowship, membership, associate fellowship, and member after day NB have been made online and objective criteria from the year 2022. NAMS has also started a new online AIIMS NAMS Navigate CME and Navigate Medico CME program to assist in the development of competencies among PG students and share multimedia learning resource materials as e-library. NAMS has also started 21 task forces to address medical issues of national importance. Under publication activities, NAMS has its own annal as Annal of the National Academy of Medical Sciences. In addition, NAMS also publishes its quarterly NAMS newsletter. For more details of NAMS activities, please visit our NAMS website www.nams-india.in or scan QR codes with the camera app.
Hi, Dr. Sonu. Good afternoon. Dr. Umesh.
Good afternoon, sir. Good afternoon, Dr. Rakesh.
Good afternoon.
Good afternoon, sir.
Hi, Dr. Jaswant.
Sir,
Good afternoon.
Dr. Jaswant, you are muted.
Sorry, sir. Hello, good evening all. Welcome to the next session of online AIIMS NAMS Navigate Medico CME program for postgraduates and young faculty member. And today's topic is really very interesting and the need of today's hour. The topic is tobacco control strategies in India with very eminent speakers. So without wasting much time, I would like to request Professor Umesh Kapil, sir, Secretary, National Academy of Medical Sciences, to deliver the welcome address. Over to you, sir.
Thank you very much, Jaswant. I hope I'm audible.
Yes, sir.
Okay. It's a proud privilege to we have again reinitiated the AIIMS NAMS Navigate program, which is being held on every first Friday from 3 to 5 o'clock. And because of transition period, we in the month of December and January, we could not do it. But again, we'll now have continuously the NAMS AIIMS Navigate program every first Friday of the month. Today, we had a very important topic on tobacco, smoking and strategies to control. We have very eminent scientists, Dr. Sonu Goyal sir and Dr. Rakesh Kumar. Both of them have been working outstanding work. Recently, they also developed a task force and completed it, and which is under submission of publication. On behalf of the council, I welcome all the participants who have very kindly joined, and my most sincere thanks to Dr. Sonu Goyal and Dr. Rakesh for helping us in restarting, reinitiating, and continuing with this program. Thank you very much. Over to you, Dr. Jaswant.
Thank you very much, sir. Thank you very much for the welcome address. So now I would like to request Mr. Ravi for the welcome address by Professor Digambar Behera, President, National Academy of Medical Sciences.
My dear young colleagues, faculty, and officials of the National Academy of Medical Sciences, a very good afternoon to all of you. With immense pleasure, I invite you all to this program. National Academy of Medical Sciences, that is NAMS India, it was established on the 21st April of 1961 with the objectives of promoting the growth of medical sciences. It was inaugurated at New Delhi on 19th December 1961 by Pandit Jawaharlal Nehru, the first Prime Minister of India. The NAMS fosters and utilizes the academic excellence of health professionals in the country as its resource to promote excellence in medical education and skill development in the field of medicine and allied sciences. The Government of India has recognized the Academy as a nodal agency for promoting continuing medical education for medical and allied health professionals and is advising the Government of India on several matters of national health policy and planning. The best in the field of medicine are part of this umbrella organization, and who is who of medical science guide the NAMS. The National Academy of Medical Sciences encourages and sponsors nationwide CME programs, symposia, and workshops in basic sciences and applied clinical disciplines. The aim of the National Virtual Postgraduate Medical CME is to facilitate the postgraduate students and young faculty members to increase their knowledge in the medical subjects, to navigate them to be more proficient in their profession and pass their NEET and PG examination to become better doctors, eminent biomedical scientists, teachers, and researchers. As a part of this responsibility, NAMS, in collaboration with the AIIMS New Delhi and 16 other AIIMS-like institutions of the country, has initiated this navigation program in the form of dialectical lectures and discussions. The program is regularly held every first Friday of the month at 3 p.m. The best and useful topics are carefully chosen, and the best teachers from various AIIMS are picked up to prepare and give these lectures. I am sure you all will enjoy these talks and will like them and found them useful in your future lives. Thank you.
Thank you very much for the message. And now we'll move on to a wonderful message from Professor Srinivas. He is the director of All India Institute of Medical Sciences, New Delhi. So I would like to request Mr. Ravi for the message from Professor M. Srinivas. Yeah, thank you.
Namaskar. At the outset, I congratulate the team behind the NAMS AIIMS Navigate CME program. Providing quality of education to our postgraduate students is one of the prime responsibilities of AIIMS. I know that our able faculty is leaving no stone unturned in achieving this mission. However, there always remains a scope for improvement. Through this unique initiative, there is an opportunity for our postgraduate students to learn from the experts in their field. This learning will go beyond the boundaries of department where our postgraduate students are working, and will also bring in more flavor in their knowledge, and at the same time ensure dissemination of uniform, high-quality content all across the nation. Postgraduate students also form our primary workforce for providing patient care. This indeed is an important component of their training. We are aware that our postgraduate students devote a large component of their time for the patient care services, and thus they have less time for self-study by the end of the day. The timing of this activity is therefore very carefully chosen. The sessions will be held late in the afternoon so that the beneficiaries do not have to make any extra effort for attending them. This by itself exudes the philosophy of a true teacher, a mentor that will handhold the children through the process of their active learning. As the sessions are online, which by its very design is a non-synchronous platform, it may seem that the delivery of the content will be one-sided, but enough measures have been planned and they are in place to make the activity as interactive as possible. The topic of the session will be shared with the students well in advance. This will allow them enough time to explore the subject and be better prepared to absorb the content. This design, therefore, also matches the concept and principles of adult learning. The program not only will help our postgraduate students in being better prepared for their examinations, but also will equip them with sufficient knowledge, understanding, and approach to be a better professional in their field. I wish this program all success. Thank you.
Thank you, Mr. Raviji. So now it's time to introduce today's eminent speakers. It's my honor and privilege to introduce and welcome Professor Sonu Goyal, sir. Sir is Professor and Director RCTC, DCM and SPH at Postgraduate Institute of Medical Education and Research, Chandigarh. Sir is also Adjunct Associate Clinical Professor at School of Medicine at University of Limerick, Ireland. Sir is also Honorary Professor at Human and Health Sciences, Swansea University, United Kingdom. Professor Goyal has supervised over 50 national and international projects as the principal investigator and is currently leading 5 projects. Professor Goyal has published more than 270 research articles in esteemed international peer-reviewed journals. Sir is also recipient of various awards and fellowships, including the Fellow of National Academy of Medical Sciences, Young Research Award by IAPSM Ford Foundation, Harcharan Singh Oration Award, Vasudeva Oration Award, J.E. Park Oration, and was awarded the Public Health Excellence of India by the Honorable Union Ministry of Health and Family Welfare in 2014. Professor Goyal is the chair of Tobacco Control Section and leads the Empower Research Group of the Union, as well as NAMS Task Force on the Tobacco Control. Additionally, Professor Goyal is the director of WHO Awardee Research Center for Tobacco Control and convener of Scientific Support Group established by Ministry of Health and Family Welfare, Government of India. So, with this, I would like to invite Professor Sonu Goyal, sir. Over to you, sir, please.
Thank you, Dr. Jaswant. First of all, can you give me this right to share the screen? There.
Yes, sir. Yes, sir. Yes.
Is it visible?
Yes, sir. Visible, sir.
It's visible. The slide is visible. The first slide.
Yes, sir. Slides are visible, sir. Currently, it's third slide, which is there, sir. So,
okay. I will
the
just.
PPT is visible, sir. Yes, sir. PPT was visible. The slide which we could see was third slide. That was visible. Yes, sir. Yes, sir.
First slide now.
Right, sir. Right, sir. Perfect, sir.
Great. So
Yes.
thank you, first of all, Dr. Jaswant, for a very generous introduction. And at the outset, I must thank National Academy of Medical Sciences for giving us the opportunity to present a topic which is very close to my heart for last 20 years, that is tobacco control. So I also want to congratulate all the office bearers, which I always call them torch bearers, because they have led NAMS to great heights. Previously, Dr. Sareem, under whose leadership I think there are lot of initiative which took place. And then our own Dr. Umesh Kapil, sir. So he actually galvanized, and he is the person always reachable, and gave us a lot of insights and got a lot of innovations in tobacco control. And we used to hold various CMEs and workshops in close collaboration with NAMS in recent years. We have almost held 3 or 4 workshops in last 2 years in close collaboration with National Academy of Medical Sciences in their auditorium. And we are about to hold a very important workshop on 28th in collaboration with the NAMS and Ministry of Health and Family Welfare, Government of India. So with this background, I will start my presentation on tobacco control strategies in India. Although we have been working in tobacco control for so long, and it is difficult to enumerate each and everything here, but just to give our audience insight on what is tobacco control and what is what is there which is going on in tobacco control in the country. Stop moving. Yes. So I say tobacco control, tobacco is a villain. So if you see right from its growth, you can see on the extreme left-hand side, there are leaves. The people who grow those leaves suffer from a lot of diseases. We have heard of green tobacco sickness. The person who grow these leaves, remain near to those leaves, suffers from various respiratory problems. And then these are processed in labs or industries. And again, those people who are making BDs suffer from diseases. And even small children who make those hand-rolled cigarette, which is known as BDs, they suffer from a lot of diseases, including malnutrition, because it quenches the thirst and also about the hunger, and people don't feel like eating after that. And after that, it comes in the market, and it is the only product in the country or across the globe which kills half of its users. That means in the lifetime, if 100 people are there, 50 will die due to tobacco use. So that is a huge, that we have not heard of any diseases except the very fatal infectious diseases which kills so many of people. And you can see a lot of cancers, name any organ, the tobacco is responsible for it. So that's why I always call tobacco as a villain. Now, how many people globally? 8 million people annually die due to tobacco use. That is around 80 lakh people. And out of them, around 1.2 million, that's around 15% or so, die. Those innocent people die who have not taken tobacco, but due to second-hand smoke. And similar figure are there for smokeless tobacco products, similar figures. And you can see on the right-hand side, among all the deaths which are taking place, 80% of deaths are in low and middle income countries. So we are the most sufferers of the tobacco. India is a unique in the sense that it is the second largest consumer of tobacco entire globe. In the list of 200 plus countries, now India is the second largest consumer and the second largest producer of tobacco. So that is the ubiquity of the tobacco in our country. The recent Global Adult Tobacco Survey gives us a thing to smile, but also a thing to frown as well. when I say that it gives a reason to smile, because of the fact that there has been a reduction in tobacco users in the country. The proportion of tobacco use dipped from 34% to 28% in adults. But 28% itself means 1 in 4 adults consumes tobacco. So that's a huge. If you see 100 people on the street, 25 are using tobacco. And I have said earlier that half of the people will die due to tobacco use. Right? So that is the figure to remember, that 28.6% people actually consumes tobacco in adults. That turned to be around 26.7 crore population. Out of that, around 20 crore are smokeless tobacco. So our main problem is actually smokeless tobacco, and 10 crores are smokers. Now you see, this is what I was saying, there was a 6% decrease from Global Adult Tobacco Survey 1, which was conducted in 2009-10, and Global Adult Tobacco Survey 2, which was conducted in 2016-17. And I just want to inform you that we will be having Global Adult Tobacco Survey 3, which will be happening this year. So we will have to see that what is the whether there is a sustained decline in the tobacco use. But you see in that graph, overall tobacco use, there is a huge variation. On the right hand side, you see the northeast states, Tripura, Mizoram, Manipur, Assam, Meghalaya. Prevalence around 47 to 64.5. 64.5, what does that mean? Out of 3 people who are there on the street, 2 people are taking tobacco. But on the left-hand side, you see Goa, Puducherry, Kerala, Punjab, Chandigarh. So they are having a low prevalence of overall tobacco. Now, this is the burden of tobacco use in terms of smokeless. That was the overall tobacco use. But when you see the smokeless, almost the situation doesn't change in terms of Tripura and Manipur. I think they are the top one. But Odisha has higher, I think 44% of people who are using tobacco against 21%, which is average people in Odisha. And if you terms as smoking, again, Mizoram, Meghalaya, Tripura, Arunachal Pradesh, Manipur, all these northeast states are consuming very high prevalence. There's a high prevalence of tobacco use, and definitely males are quite higher than females in terms of smoking. Males is 19% in smoking, females are just 2%. But in smokeless tobacco, there the difference is not that different. Like males are 30%, but females are also 13%. Now that was adults. This is burden of tobacco use among students in India, because India conducts a lot of surveys, and these are the global surveys. This is Global Youth Tobacco Survey. You can see there were 4 global youth tobacco survey being conducted in 2003, 6, 9, and 19. And overall, if you see in 2019, there have been a slight decline in tobacco use. From 8.1% in students, the tobacco smoking has decreased from 8.1 to 7.2. But there has been a lot of reduction in smokeless tobacco use among students. It has reduced from 9 to 4%. Right, so again, this is a positive silver line actually, which we see. But if you comes in terms of numbers are very high. Now, India is again the only country which has the maximum types of smoking and smokeless tobacco products. And that is why it is very challenging for the government and others to control them. There is also presence of new tobacco products and nicotine products which are banned: electronic cigarettes, vaping, pens, heat not burn products, jewel pods, and now herbal tobacco products are coming. And now now the new thing which has come in the market are nicotine pouches, because some people who are used to smokeless tobacco, they can use the nicotine pouches. The industry, which is smart enough, they have come up with those nicotine pouches. So these products are coming up in a big way, despite the fact that our country have banned electronic cigarette and like products in 2019. Nobody can sell them. If we see India's tobacco control efforts, we have law, which is very stringent law, that is known as COTPA, Cigarette and Other Tobacco Product Act. So that is the act which is there in 2003. And it was very strong act, lot of provisions which are there. And now it is going to be modified. And there are discussion going on the recent version of COTPA. And we hope to see ever strong provisions in the recent version as well. There is a framework convention on tobacco control, which is by WHO. So tobacco is first a framework convention on tobacco control. Tobacco comes like it was negotiated under WHO in 2004. So all countries, 193 countries came and they signed, and many countries ratified. So today, 186 countries across the globe have ratified this treaty. And we have a national tobacco control program in 2007 and 8. We have an illicit trade protocol, which means that the illicit products coming from across border cannot come. So there is a protocol for it. Our country is the only country in the world which has 3 national tobacco testing laboratories. None of the country have more than 2 laboratories. Our country is one of the country which has 85% pictorial health warning. So that means on the front side or on the back side of the tobacco pack, one should have 85%. Initially, it was just 40% of the pack covered. We have launched the tobacco-free educational institutions. So there is a guidelines. Every institution, educational, be it a medical college, because medical college is also a educational institution. So there are guidelines. There are 10 criterias. Every institution have to fulfill that criteria. There is a PECA, that is an act for controlling electronic cigarettes. So our recent government has come up with that ordinance. Not many countries have that ordinance. So our country banned electronic cigarette altogether. We have Article 5.3 Code of Conduct. What is Article 5.3? Because entire thing which is happening in tobacco is primarily due to tobacco industry. And Article 5.3 says that as a medical institution or as a government official, we should not and we cannot interact directly with the tobacco industry. Neither we can take their sponsorship. And whenever any medical college or any institute takes, so you should be very careful to see what is the credential of that particular funding institution. Then we have OTT rules recently. I think OTT channels are flouting all those things. We have in films, we have that disclaimer on cigarettes and tobacco, but OTT were flaunting that. So government has come with these OTT rules, and now there is a tobacco-free youth campaign which is going on. So a lot of things India has done. If we talk about the National Tobacco Control Program, this is the entire structure of it. We have at the national level, National Tobacco Control Cell, at state tobacco control cell, and district tobacco control cell. And there is a quarterly reporting mechanisms. There are different forms. I will not describe each form, but every center, from the district to the state to the national level, they have to report on the quarterly basis. Everything, including statement of expenditure, what is the work being done. And if we see the staffing pattern, which is there at National Tobacco Control Cell, we have at the State Tobacco Control Cell, we have a state nodal officer and state consultant. So if you want to collaborate for tobacco control in your own state, you can go to the state nodal officer or state consultant. And even in this district tobacco control program, we had district nodal officer and district consultant. And there are a lot of activities right from policy development, which is there at the state level, primarily at the state level, policy development, advocacy. But there is capacity building, tobacco cessation and support, and media and communication, and so on. If you see primarily at the state level, what they do, they are primarily involved in training and capacity building and implementation of the program. Training and monitoring and enforcement of tobacco control law. If you see at the district level, again, they are focused on training of key stakeholders, school programs, and monitoring of tobacco control laws. So this is how this different district DTCC and STCC and NTCC works. This was just a glimpse of what is happening in the overall structure. Now about our act, that is known as Cigarette and Other Tobacco Products Act in short form, but in full form it is Cigarettes and Other Tobacco Products Prohibition of Advertisement and Regulation of Trade and Commerce, Production, Supply and Distribution Act. Very elaborate act which is there. Now, as I told in my earlier slide, it was enacted by Parliament in the 54th year of Republic of India in 2003. And thereafter, lot of deliberation, lot of amendments have taken place in that so that to make it more stringent. Those who want to work in tobacco control, there is a act copy on the internet. I think one should read this, and that gives you an idea about how comprehensive this act is. And the prime objective of COTPA, we call them in short form, not COTPA, is to reduce consumption of tobacco product and protect the health of citizens of India. Right? So that works both on supply and demand. So it also talks about regulation of production, sale, distribution, advertisement, and consumption of tobacco products. Now, these are the sections which everybody in our medical college should know. Section 4. There are various sections, but I will highlight only 5 main sections which comes out of it, or in fact 4. The section 4 is prohibit smoking in public place. No person shall smoke in any public place. I'll give you a list of public place in my next slide, but the rules of this were formed in 2004, and later comprehensive set of new rules were formed in 2008. So initially in 2004, these rules of, because every act which is formed has rules, how to go ahead with it. Right. So in 2008, it was notified for effective realization of objectives of smoke-free environment. Right. So this was implemented since 2008. Now, these are the public places. Don't remember all those public places. Just see all the places which are enclosed places, basically. Enclosed places are public, like whether shopping mall, bar, restaurant, railway station, hospitals, pubs, airport lounges, public conveyances, everything. But only the roads, only the open roads and the houses, own houses are spared in this. But yes, there are few roads which have been notified by the district magistrate of that particular place. I remember of Mall Road in Shimla has been notified. Although it's a road, it's an open space, but then it has been notified. Even like, for example, in a school or in a medical college, the entire campus within the medical college, it should be smoke free. So if the road exists within the medical college, nobody can smoke that there. So that is again a public place. So please ensure that this type of signage should be there at strategic places. Strategic places means like wherever the persons can see easily. This signage, the size of this signage is 60 centimeter by 30 centimeter, means 2 feet width and 1 feet of length. And it should say no smoking area, smoking here is an offense. It can be Hindi like धूम्रपान निषेध क्षेत्र, यहां धूम्रपान करना अपराध है, ये लिखा होना चाहिए. And then one should write that if anybody is found smoking, please complain to. And every building in a hospital, like for example, we have neurosciences, we have other buildings, any building, one should have one nodal officer. One should be designated nodal officer, and the name of that nodal officer should be written here, and the phone number. In case somebody is found violating, that person can be contacted. Right? So this is smoking signage. Yes, there are certain exemptions in that, like you might have seen the smoke-free, this in hotels, there are some rooms in which you can, one can smoke, that is smoking rooms. Yes, but that room should not be, there are various criteria for that room. I will not detail it here, but just to tell you that those smoking rooms should be present in a separate area or a separate. It should not be like one smoking room, one non-smoking room, one smoking, one non-smoking. There should be a separate ventilation for smoking room and non-smoking room. And that is easily identifiable when you enter a non-smoking room. You can easily see the smell of that. Right? So any hotel or restaurant with more than 30 capacity, seating capacity, restaurant with more than seating capacity and hotel with more than 30 rooms can have this. Now, a restaurant which has capacity of 10, that restaurant cannot have the smoking area, because two things are there. One is smoking room in hotel and smoking area, like you might have seen in airport. Right? So these are the exemptions which have been given right now under the Act. But yes, I think if you see the newer version of Act like COTPA, which will come in maybe in 2023, so you will find that that provisions might be vanished. Now, what is Section 5? Section 5 is very important because you might find in medical colleges, around medical colleges, there are shops which sell tobacco products. So advertisement, direct or indirect. Direct means like directly showing smoking. Indirect means like gold flake. Even if you don't write the gold flake on that banner, it is visible that yellow, that colored pattern resembles gold flake. That should not be there. Indirect advertisements, direct advertisement on the shop should not be there. And it prohibits all forms of promotion of tobacco. Now, what happens? Sometimes in a cigarette pack, on a BD pack, they give an insert that if you buy the next bundle of BD or next bundle of cigarette, you will get another discount. That is prohibited. It cannot be there. And neither there can be a sponsorship. So any medical college, any institute cannot take sponsorship from a tobacco company or any affiliates of tobacco. So that is what tobacco, and I will tell you about what will be there in case they violate it. Right? These are the violation. You can see here the yellow colored board on the extreme left hand side, seeing gold flake, or even you can see those colored walls of these kiosks. So these all are violations. Now, another important point for you in a medical college or AIIMS, anywhere, is prohibition of sale of tobacco product to and by minors. Right? So this means that it prevents supply of tobacco to minors, and there should be a signage that outside each educational institution that sale of tobacco product to a person below the age of 18 years is a punishable offense. So that signage should be there. Now, Section 6B is again that there should be a signage for Section 6B as well, like sale of cigarette and other tobacco product in the area within the radius of 100 yards of any educational institution is prohibited. You might have seen in the schools, outside the school, these signages, but that signage can always be there in a medical college, outside the medical college, because yes, medical college is also a educational institute. Now, section 7, 8, 9, 10 have been clubbed in the sense because it relate to tobacco product packages. So as I told that tobacco products health warnings, which are there on the packs, 85%. So it relates that it should be legible, prominent, conspicuous, and so on. So these are various, I think, initially it was 40% before 2016, but a lot of efforts have been done by various stakeholders, primarily the non-governmental organizations, so which led to 85% on both sides. But we are not there. We are not the only country which has 85%. We are now ranked, I think, 9th or 10th. There are many countries which have 92%, 95%, and recently there is a news from Nepal that they are going to do 100%, 100% on both the sides of the pack. They currently have 90%. So this is, I think you can see the packages without warnings, loose cigarette, but this violation is very less in our country. Only violation present is about the imported products, but that is again violation. If you see this violation, that can be reported. Now, the penalty under section 4 and section 6 is very less, 200 rupees, very less currently. But in the recent, which we'll see the light of the day soon, we have proposed for very high penalty. And section 5 has a penalty of, I think, both the thing. What is compoundable? Compoundable means section 4 and 6 is compoundable. They give 200 rupees, you give them receipt, and that's fine. But section 5, that is tobacco advertisement, promotion, and sponsorship on the shop, that is non-compoundable. Means that cannot be settled there and then. It can lead to 2 years of jail or 1,000 rupees fine or both. And subsequent is 5 years of jail. And section 7, which I was talking about on the cigarette packs, I think there are again convictions of 2 years of jail and 5,000 rupees of fine. Now, just to give you some other acts, this PECA, Prohibition of Electronic Cigarette Act 2019. So it is totally prohibited. If somebody is found selling these electronic cigarettes, that person can be fined. I'll tell you what fine can be imposed. Then there is a Food Safety and Standards Act 2006. That says, very important act, because these are the act which COTPA, they are supplementing our COTPA Act. That says that tobacco and nicotine shall not be used as ingredient in any food products. No. What does that imply? So all that smokeless tobacco product, they are considered as a food items. So tobacco should not be present into it. So now there is a ban on smokeless tobacco. That means. So what does that mean? They cannot sell smokeless, but you will say that I have seen smokeless tobacco product being sold. Now they are sold separately. There are 2 pouches which are mixed, and that is being sold to counter that. Then there is a Trademark Act. Like Trademark Act also says about how that trademark should not be used, because what these companies are doing, tobacco companies, they are selling tobacco products, but they are also engaged in hotel business. In, like, for example, you might have seen ITC Hotel. So ITC Hotel is a chain, but that is being sponsored, that is owned by tobacco company, the biggest tobacco company. So I never stay there despite they are offering discounts, even the conferences, I make it sure not to stay there and not to use them. The Classmate book. So, and Ashirwad Atta. So these are some of the items which are produced by tobacco companies. So if you are consuming that, so we are increasing their businesses. So these are trademark. This is very important. Juvenile Justice Act 2015. What does that say? So Juvenile Justice Act, which was, I hope that you remember, Menka Gandhi was the one who brought this Juvenile Justice Act 2015. It says, Article 77 says, whosoever gives or causes to be given to any child any intoxicating liquor or any narcotic drug or tobacco product or psychotropic substance, everything, right? Anything of this, except on the order of duly qualified medical practitioner, shall be punishable with rigorous imprisonment for a term which may extend to 7 years. Now, this 7 years is very important. If somebody is found selling electronic cigarettes, now we don't impose KOTPA. We can impose this act because that contains nicotine, 95% nicotine. Electronic cigarette contain 95% nicotine. Very harmful. It can even cause death. There is an explosion which have taken place because of that, right? So if somebody is found, and in Punjab, way back, along with the Punjab nodal officer, we have done that imprisonment of 2 people, and that was highlighted in the news. And also about 1 lakh rupees, 7 lakh and fine up to 1 lakh. Now there is a Consumer Protection Act, which can be because it is protecting the rights of consumer against defective product or deficient services and against exposure to second-hand smoke. So I think even the Consumer Protection Act can be levied. Environmental Protection Act 1986 and Plastic Waste Management Rules 2016, because cigarette, you can see the sachets, plastic materials, right? And recently there was a news about stubs, the cigarette stubs, that is quintals of cigarette stubs were found in the ocean and a lot of marine deaths due to them, right? So plastic material in any form shall not be used in any package, cannot be used, right? So Drug and Cosmetic Act, I think this was the act under which Punjab was the first state in 2013 which banned electronic cigarettes. Because they say that that Drug and Cosmetic Act says that nicotine is a poison and electronic cigarette contain 95% nicotine. So Punjab banned electronic cigarette way back in 2013, and after it, many states did it, and in 2019, Government of India did for entire country. Even the Motor Vehicle Act, we can't smoke within a motor vehicle, right? So that is because that motor vehicle, there are other people who are there. So I think these are the glimpses of what are the things which are there in our country, including various strategies for tobacco control and related tobacco control act. So I finish it here in the interest of time, and I give it to the organizers for further proceedings.
Thank you very much, sir. And that was an excellent presentation, sir, regarding strategies for tobacco control in India. So I think, sir, the question answer session will be held after completion of both the presentations. So now I would like to welcome Professor Dr. Rakesh Gupta, sir. Sir is president of Rajasthan Cancer Foundation at Jaipur. Sir is former associate professor of surgery and he is surgical oncologist, member of expert committee for Ministry of Health and Family Welfare. He is also a member of core committee of NOHP and the task force of NAMS on tobacco cessation countrywide. Sir is also trainer for tobacco cessation, TCC related human resource awarded by Director General of WHO for his work in tobacco control in Southeast Asian regional offices in the year 2013. As a keen academician and researcher Beside 20 peer-reviewed publications and over 100 presentations in last 7 years, he has authored 2 books on tobacco control and cessation, तंबाकू मुक्ति की ओर and तंबाकू नियंत्रण के मुद्दे. His works include systems approach in tobacco cessation delivery, quit line in India, and engagement of state medical helplines to deliver tobacco cessation. Provided model for the smoke-free city and tobacco-free workplace media advocacy campaigns. He was also the director for India for American Cancer Society that established the maiden quit line for India in 2008 till 2010. He also represented India in Asia Pacific network of quit lines. So with this, I would like to welcome Dr. Rakesh Gupta, sir. And the topic that he is going to present is again an important aspect, and that includes challenges, opportunity, and way forward on tobacco cessation. So over to you, Dr. Rakesh Gupta, sir.
Thank you, Dr. Jaswant. And at the outset, I would like to thank the NAMS organization as a whole and our guest speakers, Dr. Bera and Dr. Srinivas, and much grateful to Dr. Umeshji for giving us this opportunity. I feel very privileged to address all the people who are the participants here. And I thank Dr. Sonu, my friend and a colleague with whom we have been working in tobacco control. He has been a leader in tobacco control at the national level to push us all together to work for tobacco control, make it stronger. And I must tell that, yes, it's a time that we start thinking of end game for tobacco. And there also he is providing the leadership. Now, looking at the numbers of the participants and the structure, I have a question which I thought will be relevant and will be useful to the participants. And if you can respond in the chat box. How many of you are postgraduate students and the faculty separately? Can you please respond in the chat box? And Dr. Jaswantji, you may let me know as to how many are PGs. Because although I had prepared my topic for establishing tobacco cessation clinics in medical institutes, I consider the delivery or learning of the delivery of the tobacco cessation, the actual process perhaps might be more useful as postgraduates. So if that is so, I will shift my presentation to another one which has been done earlier, but I think it will still be useful. Great. I'm still waiting. Yeah. So it appears most of them are the MPH students, and that's great. Yeah, and
majority are students, sir.
Basically students.
Right.
So, if you're given me the co-host rights for sharing my presentation.
Sure, sir. Please, sir. You can, sir.
Yeah. This is the one I thought I'll present, but let me go to the another one. Yeah. So I think this will be more useful, and let me go to the slide show. Yeah. Is the slide seen clearly, and am I heard?
Right.
Okay.
Yes, sir. Slides are seen.
So why quit tobacco? I think that is very important. And we have to know two things. Tobacco use is a disease, and hence every tobacco user is a patient. Now, this is an evidence-based categoric statement as per the International Classification of Diseases, edition 9 to 11. So it's not something that I am telling because I am working in tobacco control or I have specific motivation as a surgical oncologist and as an Indian who considers that if about 3,500 people, adult Indians are dying due to tobacco related illnesses, people should focus on quitting. I consider that it's a disease we have a responsibility as the health professionals that we treat it. It should also be known that nicotine addiction is the worst than all other addictions. This again is a biologic fact. The people who have been using other drugs and substances, it's easy to treat them as compared to nicotine addiction, which comes in early and is difficult to be treated. So these two facts we have to remember in reference to tobacco quitting as such and overall tobacco use by the people. Also, one should know that there is no safe tobacco product, nor there is a safe level of its use. So if somebody says कि साहब मैं तो कभी कभी लेता हूँ, वीकेंड पे ले लेता हूँ, अब ले रहा हूँ तो कम कर दूंगा, all this is not going to help that person. It's very important that the person who is a current user of tobacco quits tobacco at an earliest. It has been known that if you quit early in your life, you can save otherwise what is considered as 6 to 10 years of average loss of life for somebody who is a lifetime user. So it's very important to remember that tobacco is not safe, tobacco is toxic, tobacco kills. These are the facts which are to be remembered. For non-users, the best bet is to avoid it altogether. And many of us, as Dr. Sonu has already shown, that over 70% in India do not use tobacco. So we have a large population who is not using tobacco, but they have a responsibility. One should understand that they should also help the users to quit tobacco at an earliest. This is the study that I think everybody of us should know. It's a prospective study done for 50 years in 34,500 male British doctors who were smokers. Remarkable study, I think sentinel study world over, which showed for the first time that the lifetime smokers lose 10 years of their life. They die prematurely. And if those who continue to smoke, as Dr. Sonu also said, half of them will die of tobacco related illnesses. So these are the two facts which came from the prospective study. So it's important to remember these two facts as well. Also, the graph which is here, which shows very clearly that if you quit early, you will make up for the losses which will otherwise occur if you are a lifetime user. But quitting helps, and quitting at any stage of life is helpful. So it's very important that we remember quitting benefits regardless of the age. What are its benefits? I think these are given, and a Google search will make you very much more educated than what I will tell you briefly. I'll just say that the benefits begin within 20 minutes. You'll find that within few weeks and months, the cardiac and the pulmonary functions have recovered completely. After 1 year of quitting smoking, the risk of coronary heart disease is almost half of that of a smoker. Within 1 to 4 years, the risk of death falls to half of a person that continues to use it. In 5 to 15 years of quitting smoking, the risk of death due to ischemic heart disease is halved, and the risk of stroke is also reduced to that of a non-smoker. Within 10 years of quitting smoking, the risk of lung cancer falls to half, and the risk of other tobacco-related cancers also start reducing. So overall, in 15 years of quitting smoking, your body is revived so much that if you did not suffer meanwhile from any tobacco related illnesses, you will be like a person who never used tobacco. So that's the immense benefit. I always say that investment, wherever you make an investment, it will help. If you'll continue to use tobacco, your likelihood to get a tobacco related illness will be very, very high. But if you quit, it is highly likely that you will be free of the tobacco, suffering from the tobacco related illnesses and a premature loss of life, which affects not only the person himself, but his family, the society or the organization he works for, and also the country due to the productivity loss and economic loss. Quitting helps even when one person is ill. So quitting reduces the risk of diseases of coronary artery disease by 50% or more. In case of pulmonology, there is symptomatic relief, there is reduction in infection rates, multi-drug resistance in tuberculosis, and overall mortality. In case of oncology, risk reduces the risk of dying in cancer patients reduces by 30 to 40%. It improves response to the therapies and risk of recurrences and second cancer as well. Lastly, in diabetes, it also reduces the risk of coronary artery disease, stroke, peripheral vascular disease, etc. So, quitting helps even when somebody is suffering from non communicable disease, or these are all more or less tobacco related illnesses. So, quitting helps even when a person is sick. There are also some other impacts of quitting tobacco. The biggest effect I consider is the behavioral and psychological impact for a person as such. There's a better control over emotions, anger, frustration, etc. There's improved stress management and performance, improved decision making. There's a big social impact in the terms of the relationships within the family and in the society. There is an improved work life balance for the person. There is a huge financial impact. Almost 10% of the people who are in extreme poverty, they are poor because they are using tobacco. So quitting also helps you to take out of the poverty, because 10 to 15% of the earnings that you're using, which you could otherwise use for your family welfare, I think it gets lost, and that is why people feel the impact of poverty. And lastly, there is an environmental impact that one has to remember, that tobacco is one big environmental hazard, and it has been known that cigarette butts are the biggest hazards which we have seen. But tobacco products in any form, if you throw it on the ground, it gets seeped in the soil through the water. It will contaminate the water. It will contaminate the crops which are grown. It comes into form of toxins in our food items. And lastly, I would say that the study which has been done by ICMR some 2 years ago has shown that every year India is producing the tobacco waste products, which is equivalent to 33 Boeing 707. That much of waste product we are producing to the tobacco use. So it's time that we consider all the impacts of quitting tobacco and become tobacco free. Quitting is difficult, as I have told you. The withdrawal is there, both physical and mental. Physically, the body reacts to the absence of nicotine. Mentally, one is faced up with giving the habit. A major change in behavior is required. And emotionally, one feels like as if one has lost the best friend. I know the people who would say that if I will not use tobacco, the life is not worth living. I consider it's time that people think of changing the behavior, that nicotine addiction can be treated. It can be done through the behavioral change, and it will also help in management of associated illnesses, which I think can be corrected simultaneously. As I told you, nicotine in tobacco, imagine if it is not there. People will not be using tobacco. And that's what tobacco industry is currently doing, that once it has been sort of deciphered, has been held responsible for so many tobacco related deaths, which almost amount to 19,500 deaths daily in the world due to smoking. Consider they have shifted to the nicotine products, the innovative products as they call. They are considering these are harms reduction product in form of e-cigarettes, but that's a kind of facade. This eventually nicotine addiction will take a person to the use of tobacco. So we all know what is the definition of the addiction. It's a chronic relapsing condition. Analogy is a sick person works to be sicker until there is a life. So I think addiction is something which is very, very serious condition to be treated. The people, the way in which they use tobacco, I consider the use is from experimentation to habit to addiction to disease and death. I consider that would be helpful to know. People should know in tobacco cessation what are the triggers, person, place, and time. These triggers are very important to be known when we are counseling a person for quitting tobacco, because they will have to kind of eliminate all these factors to be tobacco free and to stay tobacco free. Not saying that you don't go to meet the people whom you love and you work with, the places you want to visit, the times of the day, but but I think the modifications can be brought in here. And in nicotine addiction, I would say it is a psychoaddictive substance that adds to force to the self-administration because of several substances which are secreted in our brain. At the midbrain level, it starts working and then it affects the prefrontal cortex. It creates, in a way, a psychiatric chaos. And nicotine, although it gets eliminated, sort of eliminated through the liver and the kidneys, one has to know that treatment is important. Nicotine addiction treatment requires management of withdrawal symptoms, and that can be done by the treatment with the appropriate drugs for the best results. Nicotine addiction, as the picture shows, the nicotine enters in the blood, in the brain through the blood-brain barrier. It stimulates the nicotine receptors, leads to the dopamine release, and then it gets to the prefrontal cortex to cause the adrenergic actions. Some reward pathways gets stimulated, and as I told you, nicotine deprivation leads to the withdrawal symptoms. A simplified way to assess the nicotine addiction is that if somebody is using tobacco product for any tobacco product for over 10 times in 24 hours, if somebody is using tobacco within 30 minutes of waking up, if the abstinence of tobacco precipitates the withdrawal symptoms, or the person uses it despite suffering from tobacco related illnesses. These four simple criteria, which the quit lines use to identify the nicotine addiction, I think are much more useful, easy to recall than the Fagerstrom scale that has been recommended. One can remember, I have no objection to that, but I consider there is a simpler way to categorize a tobacco user as a nicotine addict. That is that there is a craving for the object of addiction, that is tobacco. There is a loss of control over its use, and there is a continuing involvement with it despite the adverse consequences. Now, coming to tobacco dependence treatment, it's a two-part process, I would say. One is the behavioral aspect, the habit of using tobacco. I told you about the time, place, and person. That changes requires a change in the behavior. And the second aspect, which is physiological, which is the addiction of nicotine, one requires medications for cessation. It's important that treatment addresses both the physiologic as well as the behavioral aspect. It's not enough sometimes just to counsel a person. The person will require pharmacotherapy as well, which is very simple. We'll come to that in a moment. The behavior one should know is the most challenging task for anyone to change. Put yourself in the shoes of a user and you will see that it is the most difficult thing to do in your life. It's more so if this is the part of one's life for many years. The user is so very adept in using tobacco, the associated thoughts, the body movements, the people, the environment in which he is using tobacco. Consider all that. And doing so repeatedly, every day, every week, every month, every year, for many years. I think that's where the challenge lies. In quitting, therefore, the counselor is directing or motivating the tobacco user to change his or her behavior. It primarily means you empathize, to be compassionate and committed to assist the user in making that change. Many times, the healthcare professionals particularly feel very frustrated or disappointed that a person, despite his repeated instructions, is unable to quit tobacco. But take it in your stride. Keep your door open. It's very important that a person who is suffering with a behavioral disorder will require time. And many times people have to quit, make so many quit attempts before they really succeed in quitting tobacco. I may just be reminded about the time anytime when my time is over, although I'm taking care that I stay in time, but perhaps it might take another 5-7 minutes more. So, coming to this unique approach that the hospitals should adopt, it is called systems approach, which means that any patient who is coming to any health facility should be screened for tobacco use, should be asked two questions. One is, are you using any form of tobacco? In Hindi, if it is asked, क्या आप कोई तंबाकू खा पी रहे हैं? क्योंकि कई बार क्या होता है, अगर आप पूछेंगे आप तंबाकू काम में लेते हैं, वो कहेगा जी नहीं लेता हूं, अल्दो वो स्मोकर है, उसको लगेगा तंबाकू खाने के बारे में पूछ रहे हैं. But somebody who is using otherwise the or is chewing tobacco, and if you ask क्या आप धूम्रपान करते हैं, तो वो उसके लिए मना कर देगा. So it's very important that the phrasing of the question is very important. Are you using any form of tobacco, और क्या आप तंबाकू खा पी रहे हैं? The second question, if somebody says no to the current use, have you used it in the past? These two questions should be asked through our hospital information system to all the patients, and those who are tobacco users should also be preferably identified. So when they reach their respective primary clinician, the clinician knows that he has to counsel this patient for tobacco use. Then comes the second part of the systems approach, that is treatment. And treatment can be done by any doctor, any nurse as well, I would say. And you can do it through the several interventions, which I'll briefly mention in the next slide. And then we have, after treatment, we have to follow up these patients for at least 6 months. The follow up, they will not come physically for follow up. So it's better to do a telephonic follow up in them. So this is what we need to really think of. Now, before I go to the counseling proper, I need to tell you one more thing. This is the trans-theoretical model or Prochaska cycle of the change. How the behavioral change comes, how can we categorize the tobacco users? And this is very interesting because the GETS2 Global Adult Tobacco Survey, second round for India, has shown that 80% of the tobacco users do not wish to quit tobacco in next 12 months. That means we are left with only 20% of the people who are in contemplation. They are thinking about quitting tobacco and they're asking, tell me how I can do it. And then few of them come for quitting tobacco, that they are ready to quit. So out of that, you can say that 60 to 70% you will be able to, if you counsel and give pharmacotherapy, you will be helping them to quit tobacco. And if they continue for another 6 months or more, or they become lifetime tobacco free people, I think that percentage will still be smaller. And also one has to know that some of these who have been long-term quitters or successful quitters of tobacco, they can again get back into tobacco use, and again the same cycle may be repeated. So it's very important that we follow up these patients, we categorize these patients, whether they are in pre-contemplation, contemplation, they are ready to quit, or have they quitted. I think these are very important issues to be remembered. Now, counseling follows two processes primarily. One is called cognitive behavioral therapy, and second is motivational interviewing. Cognitive behavioral therapy is a kind of directive therapy where you instruct the person, you do this, if you will do this, it will help you in this, or you don't do this, and you will stay able to stay tobacco free. Motivational interviewing is little more exhaustive, elaborate, but it is also more rewarding because you are asking here a person to take the decision by himself. Any adult who takes the decision by himself, he will abide to that decision versus a scenario where you are instructing that person that you do this. There will be many people who will follow this. So I think it's important that if the time permits and the situation permits, motivational interviewing is used, or the open-ended kind of questioning system is used rather than a directive behavior. Now, there are three ways in which the counseling can be done. It can be done in a busy OPD in a very quick manner in 2 to 3 minutes, which we call as minimal intervention. You can do it over a little longer period, 5 to 10 minutes. It's called brief intervention, or we follow the intensive intervention as we do it in tobacco cessation clinics, where we spend 15 to 30 minutes of our time counseling a person on every aspect of his tobacco use and help them know what can be done to quit tobacco. Intense duration and intensity of engagement definitely helps in reaching a higher quit rate. But I consider if you don't have much time, It's best to do the minimal intervention or brief intervention and refer them to the tobacco cessation clinic or national quit line for further help. Now, the principle in all these kinds of interventions are very clear. You follow 5 ways. Ask a person whether he or she is a tobacco user, advise in a clear, strong manner that you quit tobacco, assess whether he is willing to quit or not. If he is willing to quit, assist him to quit, provide him pharmacotherapy, and arrange for the follow up. This is 5 ways, very clearly. If you are too busy, follow, ask, advise, and refer to the tobacco cessation clinic or quit line. This is what we do in our dynamics of helping a person to quit tobacco. Now, you assess a person and you find that this person is not ready to quit. I think one needs to follow another kind of strategy, what we call as 5 Rs, which takes us to relevance of tobacco use by this person. Now, here all the things which are done at an individual level. So, what is the relevance for this person to use tobacco? What are the risks that he knows which he will incur when he is using tobacco and is unable to quit? What will be the rewards or benefits of quitting? What actually are the roadblocks for that person at that particular moment when he is with you? It's very important that somebody might not be able to do that in next 10 to 15 days. And that's fine. I think you can bring him back for a counseling session again if he is unable to do it at that particular moment. And then those who are able to or get ready to quit. And let me tell you that if you take trouble to take a person to all these 5 Rs, almost 50 to 75% will be say, okay, doctor, hell, I am ready to quit. Please advise as to how I can quit. And yes, your counseling, little elaborate counseling and pharmacotherapy will help such a person. But if this person is not ready to quit at that time, and your conversation positively, welcome him to come anytime to you whenever he or she is ready to quit, and the same process can be followed. So, this is a key chart which I think should be there in all OPDs for every doctor to keep reminding himself that this is how you can help tobacco user to quit tobacco, save a life. Even if you save one life, I think that is worth it in a day, and we have opportunity to do that several times, several hundred times in our professional careers. The process that I am using is what I will brief. It is a 10-point agenda that I use, where I do the rapport building with the person to know him more, what he is doing. Then I ask him for the history of tobacco use. I assess the effects of tobacco use on his body and of abstinence. Then I ask whether he has quitted in the past, or the quit history, which has been the latest attempt to quit. Why is he quitting? Why did he quit at that time? Assess his knowledge of the adverse effects of the harms of tobacco and the benefits of quitting. Does he know that? And you will be surprised that even many medical professionals do not know in the details about the harms of tobacco and the benefits of quitting. Having done this, then we help them decide on a quit date. Quit date is something which requires a decision as clear as the fact that this is like your birthday, or this is like your Aadhaar card number, or this is your voter ID. That you have to remember. You can't change all these 3 facts. So, quit date, if you will not change once you take a decision, then the success to quit becomes very high. Then one has to be told as to how to stay tobacco free, what preparations they will require. It's almost similar to getting ready every day for the job, that you need to do certain things. मैं तंबाकू खरीदूंगा नहीं, खाऊंगा नहीं, कोई देगा तो मना कर दूंगा, किसी के साथ जो है किसी से मंगवाऊंगा नहीं. All these things one has to learn. This is all a behavioral issue. Skills also. I consider in quitting tobacco preparations to stay tobacco free and the skills to stay tobacco quit. These are two most important things, and add up the management of the withdrawal symptoms. If a person follows all these 3 points that you discussed in detail with him, you will see that the quit rate becomes very high in these people. Lastly, we will talk about the relapse prevention also very briefly. And if the person has come in as a walk-in patient, I think we have it's an onus on us to do the clinical examination and send this patient for relevant investigations to rule out the presence of any tobacco-related illnesses. I will skip some of these slides, which I think will require a longer period of time in the interest. I have talked about it. Managing relapse, I think, is very important. People should know what relapse is. Relapse means one gets into tobacco use again. There are two situations largely of extreme joy and devastating grief. These are the situations like a festive situation, a marriage in the family, or the birth of a new child, or promotion in the job, or somebody loses a near dear one, somebody gets a transfer or demotion. I think those are the times when somebody who had used tobacco in the past may again get back to tobacco use. One has to differentiate this process from the slips, which many times we experience that tobacco user by mistake, accidentally, sometimes happen to use a bite of tobacco or smokes a cigarette once in a while, but again quits it immediately. Somebody who is using tobacco after quitting it successfully for more than 3 days on the occasions, several occasions, I think is a person who has gone into relapse. He has to get back to tobacco cessation again. Understanding the withdrawal symptoms, I think, is a key, as I told you. There are several withdrawal symptoms that one may encounter, but it's important to remember that these are the manifestations of nicotine deficiency, which doesn't remain in the body forever. Not everyone suffers from all these. These are transient only. Majority of these last for a week or two, rarely over a month. Nobody dies because he has quitted tobacco. That one has to assure that person who is quitting tobacco that you are not going to die from withdrawal symptoms. Tell them in the management what is the basis of their withdrawal symptoms and that we can treat this symptomatically. Use of pharmacotherapy reduces the intensity and the frequency of these symptoms. I think hopefully this will help you to know more about the withdrawal symptoms. The follow-up is required to be done. And as I told you that if a person cannot come in tobacco cessation clinic, a telephonic follow-up is more important on third and seventh day, and at the end of first, third, sixth, and 12 months. This there is an evidence that even if you are able to do the first three calls, the quit rate is pretty satisfying in most of my in patients. In my own experience, the quit rate still stays around 60 to 70% at the end of the third call. But if you follow up the patients for a year or more, you will see that your quit rate comes down to 30 to 40%, which is the experience of many studies. And I think that's one has to do if you really want people to succeed in quitting tobacco. Now, follow-up call is a very short.
Take that time.
Yeah, okay. Give me 2 minutes. I'll finish it. So, follow-up calls is a very short call of 2 to 3 minutes where we ask a person for his well-being, his current use, if he's not sure whether he has used it in last 30 days or in 7 days, and categorize the outcomes uh, in this form that whether this person who has quit but it's less than 1 month, it is staying quit. A successful, it's somebody has quit for more than a month. Failure to quit is FTQ. Non-responders are those who you are called on third day, fourth day, and seventh day, and they don't respond to your call. So I put them in failure to quit, and then somebody after successful quitting relapses. So this is the way we categorize our results of quitting at the end of the quitting process. Now, supportive environment is very, very important. People around you have to be positive in their attitude and approach and available. And somebody who is a user of e-cigarette, I think quitting doesn't differ in any way from a routine use of a traditional tobacco product. I won't go in that. And so to, I think, conclude here in the preparation, these are the determinants of the successful quitting. Somebody who is in the preparation phase of the Prochaska cycle or theory of change. This is the person who is likely to quit. Somebody who has an access to quit portal, TCC nearby or national quit line is a person who can quit. Somebody who doesn't change the quit date, this is likely to succeed. Optimally implements the skills to stay quit, lives in a tobacco-free environment, uses pharmacotherapy optimally, and is followed up regularly, has adequate support at the social support. I think these are the people. The people in these categories are more likely to succeed in quitting tobacco. I will not go in this at the moment, and I will leave this part. So, to sum up, cessation delivery is the combination of counseling and pharmacotherapy. Counseling aims at a behavioral change. Counseling should be mandated for all those who are tobacco users at every clinical encounter. Each time, using systems approach will help the most. Patient needs skills and a tobacco-free environment to stay quit. To minimize the relapse, we need to manage the withdrawal symptoms, and equally important are social support and tobacco cessation measures. I will end here, and over to you, Dr. Jaswant, again for taking the proceedings further. I
Thank
hope.
you, sir. Thank you for the session, sir. The first question, which was asked over YouTube and is directed for Professor Sonu Goyal, sir. Wonderful session, sir. Thank you. And are there any provisions for the control of surrogate advertisements? Since we see many during cricket matches and TV by the prominent public figures.
Yeah, thank you for this question. I think, yes, I told in my presentation that our law, that is COTPA, is a very comprehensive law. There are a lot of provisions into it, but the problem lies in its effective implementation. So yes, I think there are a lot of advertisement which we see in the cricket, this thing, and some active people like active NGOs or government approach them and even find. I remember in Mohalli when there was a match which was going on, I think 10 years back. So there was challan which was done for a person who is a very celebrity smoking, and also for those type of banners which was being displayed. So these are implementation issues actually. So which can be done. We have the law to it, and that is why this type of orientation and awareness is very important.
Thank you, sir. I hope this answered the query by Dr. Preeti. So the next question is asked by Professor Uma Garg, ma'am, from BPS GMC, Kanpur Kala. So, ma'am asked, what about flavored hookahs in city? So, these are the challenges that our youth is facing. Like, these look very fascinating, and many young generation, mainly adolescents, mainly the newly, uh, 18 turned adolescents. So, they are very much fascinated towards hookahs. So, how we can overcome this challenge, Rakesh Gupta, sir?
See, there is a provision in the law that will prohibit the use of hookah in any restaurant, which is currently being done in many cities and almost everywhere. I think passive smoking is the prohibited under the Section 4 of COTPA. But largely, the issue is the poor enforcement. And I consider the enforcing agencies have a big challenge. How often can you reach to these hookah bars? You go once, you penalize them, and then thereafter, after a transient period of closure, they will again start. Many of these places, they don't even let you go in. I have tried to do that even in some hotels. And they will say, आपको क्या फर्क पड़ रहा है? आप क्या हो? आप बताओ अपने बारे में. And not many people like to get into this mess. I consider the government has to be a little more strict on this. The penalties needs to be increased, as Dr. Sonu rightly said. The COTPA penalties under Section 4 and Section 6 require a revision. I consider penalties should be deterrent. It should go in thousands of rupees for an individual and organization. We need to know that the law, if it is there, it is to help people, but people need to abide to law, and that requires accountability on the side of both the enforcers as well as the people. I hope it satisfies.
Thank you, sir.
Thank you, Dr. Umaji, for asking that
So
question.
next question is from Dr. Medha Sala. We would like to implement your tobacco counseling and control strategy in our CHC.
Okay.
Do we need a separate tobacco control center? for this, or can this be implemented in NCD clinic in the CHC? Also, please share us the strategy.
Yes, I think it's possible to do that. And although I had not given my presentation for establishing a tobacco cessation clinic, per se, establishing a tobacco cessation clinic does not require a lot of paraphernalia. If somebody is committed, somebody knows how to do the counseling, as a table and two chairs in front of him to let a person and a close relation sit and have time to talk, I think that is all you require. But if you have a kind of a room which is there labeled as tobacco cessation clinic, all the more better. And in the tobacco cessation clinic, if you also have a computer desktop with the sort of recording that person's data, I think that will still be helpful, because eventually it is very important that we maintain the record of our patients to know how many we need to follow. And if we follow them up, we will also know how many of them have been able to quit, which is the test of our own efficiency, as well as something for us to report on the reviews and also to share it with our colleagues as to how we are doing in tobacco cessation. So I think it's just a process. It is not very difficult. I was thinking to make the presentation, but I think that if you are running a tobacco cessation or thinking to run a tobacco cessation clinic, more important is the concurrence and the leadership which is required upfront from the CMHO or the PMO or the principal and controller, who will do it and how he does it out of his own. Because generally, this is my apprehension, and the government has given a directive for all medical colleges to start with the tobacco cessation clinic. The problem is, who is going to run this tobacco cessation clinic? Whether he is an internist or a gynecologist or a community health person, who is going to do it? How long will they do it? Can tobacco cessation become a standalone service where you have specific staff for it? These are some of the questions I think in the times to come we will be able to resolve. I think we require people who will be able to help specifically give their time to help a person quit. But doing it so is not very easy in a medical institute until you have a very separate staff for tobacco cessation clinic. That is what my perception is of having worked in medical colleges for nearly 22 years, and as I perceive it now as well.
Thank you, sir. Next question is for Sonu Goel, sir. Sir, one question on the images on packets. What if the images are zoomed up or not clear? So,
Yes, I think one-liner answer to it, that it is violation of section 9, section 789. So this is a violation, and that person can be imprisoned under COTPA for 2 years, the person who is selling it. So again, if we should know the act. The only thing is, like, if we know about the act, we can ask the authorities to implement that particular act. And also, just want to inform you, besides that, there is an act known as Meteorology Act. Meteorology Act is about weighing. So they say act under which the punishment is minimum 25,000 rupees. So I think that meteorology officials are also part of that task force, or which goes for survey and does this. So they can also levy fine from their own. So these are the things. Yeah.
Thank you, sir. Thank you.
so the next question is regarding, okay, your views on treatment of suggestion by using patches, chewing gums, effectiveness, and any Indian data available from Dr. Sangram.
Yeah, very good question. I think I did not elaborate on nicotine replacement therapy or as such on pharmacotherapy because of the shortage of time. The nicotine replacement therapy is available in the form of nicotine gums, nicotine lozenges, and nicotine patches. I consider that using nicotine gum or lozenges in 2 milligram strength alone suffices. What is more important when you prescribe this to the people, they should be told that this requires to be taken for at least 8 to 10 times or 12 times a day as you were using tobacco. These are the nicotine gums or lozenges are kind of providing a supply of nicotine of which they are deficient when they have become tobacco free. That is one thing that they should know, because most of the people who fail to quit, they do not use the nicotine gums or lozenges for more than 2 to 3 times a day. Use of nicotine patches is costly, cumbersome, has side effects in the form of skin irritation, itching, etc. I do not prescribe these to the people who can use nicotine gum or lozenges, and I use it specifically if somebody is unable to swallow or chew nicotine gums or lozenges. That is my strategy. Or somebody has a job where you need to speak a lot, then perhaps keeping something in the mouth is not helpful. Also, it's important to remember in use of nicotine gum and lozenges that you tell them how to use it. They have to chew or suck it slowly, use it until the effect of tobacco that they used to get, they have obtained that. And if more than 50% of gum or lozenges is still left, you can park it between the gum and the cheek and use it next time again. But also, when you have used it and you have got that kick, particularly of the nicotine use, do not take anything by mouth for next 15 to 20 minutes. These three things are very important. Chew slowly, stop it when you got the kick, and do not take anything by mouth for next 15 to 20 minutes. These three things, unless you tell the person, your NRT therapy is not going to work. But NRT therapy otherwise is pretty good therapy, a standalone therapy. However, almost 50 to 60% of patients require addition of bupropion. Bupropion, which is classically an antidepressant drug, is the specific drug which acts on the nicotine receptors through the substrate competition. And it's an antagonistic drug to the nicotine. If it is used simultaneously with nicotine replacement therapy, you have to tell the person the effect will come in next 7 to 10 days. Do not stop this therapy for 2 to 3 months time. And we do not give bupropion to the people who are alcoholics, who have the history of convulsive seizures, and who otherwise have a history of recent head injury. We do not use nicotine replacement therapy as well as bupropion in all the people who are minors below 18 years of age, the pregnant women, and the lactating mothers. These are the cautions to be undertaken.
Sir, thank you, sir. So the next question directed towards Songoy, sir.
Yeah.
Sir.
What I'll do is, in the interest of time, I know that the time is less. So in the interest of time, this is a very common question which is in tobacco control fraternity. This is asked, and I think I really appreciate that Dr. Kunal has asked this question. Why not ban tobacco? If it is a problem, why we are keep on supplying tobacco? Why not ban? So it's not a very simple answer. I am not sure whether I'll be able to answer it. I have answered it almost like 100 times now in different forum. So tobacco is first of all a behavioral issue. So like if we just ban tobacco, so such a, like Dr. Rakesh has told, nicotine is such a poison, or it's such an addiction. If it is even more than heroin or highest form of addiction. So they can procure it from somewhere. Bhutan is the only country which banned tobacco, and Bhutan prevalence of tobacco use was 34%. So this means 1/3 of Bhutanese adults was consuming tobacco despite having a ban, total ban of manufacture, sale, and everything on tobacco. So this is number one. So we have to work upon behavioral aspects. So that means the demand side rather than the supply side. So if we reduce the supply side, the demand side will produce. This is number one. Number two, tobacco is not like other diseases, which is controlled by just one ministry. There is one Ministry of Health which tackles primarily tuberculosis, Ministry of Health and Family Welfare, leprosy, Ministry of Health and Family Welfare. But tobacco is tackled by 13 ministries. So if you talk about trade, if you talk about commerce, if you talk about agriculture, so there are 13 ministries involved. So that is another reason why there is and some ministry doesn't want it. And there is a board, tobacco board, which promotes tobacco. It is a board in the government which promotes tobacco. So that is another thing which is, I think, very strange fact which everybody should know. I think that is why it is a bit difficult than other diseases. The third thing which is very important here is like, for example, tuberculosis. The pharma industry doesn't want that tuberculosis, it is not against us. They are supplying the drugs actually. So even for leprosy, they are supplying drugs. But what about tobacco? There is a tobacco industry which supply the products. They doesn't want tobacco to go, right? And it is a very powerful in terms of money, in terms of power, in terms of political pressure. So that, but nonetheless, I'm not saying all these dismal facts, but nonetheless, over a period of time, there has been various campaign. And as Dr. Rakesh Gupta has said, maybe the time will not permit, but now the tobacco end game. Now, many proponents have come for tobacco end game. There are various countries which have proposed, and there is also a tobacco-free generation that after a certain year, the people will not take tobacco. So I think there are different concepts which are coming now. In the interest of time, I'll not take this. But yes, I think tobacco is a complex issue.
I think
Thank you,
there is
sir.
a last question
Yes, sir.
on the addiction potential of addiction developing after the nicotine replacement therapy. In practice, it is rarely seen, and if it is, it should not deter one to not to use nicotine replacement therapy, because you first want to treat the withdrawal symptoms. And once you've treated withdrawal symptoms, the body is remarkable. This itself will indicate that there is no use of nicotine. So there are very, very few people in my practice and of over 12 years in tobacco cessation. I have hardly come across the patient who will come to me that I am unable to quit nicotine, lozenges or gums. But because there is almost, I would say, 40 to 50% patients who were lost to follow up or had failed to quit, and to whom I have not followed for more than 5 years. My cohort of 1,000 patients, I have followed them for over 5 years. So I can say very authentically that the risk of addiction is very less. If it happens, I think we can do the counseling to these people and help them quit also.
Thank you, sir. So my last question from my side, and that was asked in one of the conferences. So Sonu Goyal sir, senior professor, lady professor, she asked that while drafting COTPA and other regulations, as you mentioned also, why there is a designated smoking room at airport and in hotels. So why can't these be removed? Since these are a cue for nicotine craving, because once you see a room, you get a craving to smoke. So it induces a craving. So why it was inducted in the policy at the time of its drafting? So look, that was a
Yeah,
question.
it's again a very good question, and I think this is how the negotiation happens. You know, when I think when the policy are being formed, so various actors are there, because it's a policy. Like when we used to teach, Dr. A.K. Sood is here, sir is here, sir used to teach policy. So how various actors actually play different roles and how the negotiation happens. So this is the good example of that. But yes, I think when you see the next version of COTPA, which might see the light of the day in another year or so, you might see those exemptions will go away. So I think there are other exemptions as well other than this one.
If I may just add here, it's an example of tobacco industry interference.
Yeah, yeah.
Tobacco industry influences the preparation of an act or legislation. That is very important to be remembered, that the governments are unable to do it, and therefore sometimes it takes more time. We have suggested it in the COTPA amendment to come, that we eliminate designated smoking areas altogether in our act.
Thank you, sir. So, on a positive note, we can see that, as you mentioned, that in a global adult tobacco survey, the prevalence was less than the gets one. So there was a good and positive direction for our country. So with this, I would like to thank again to both our eminent speakers, and I would like to invite Professor Ajay Kumar Sood sir. He is Deputy Secretary for National Academy of Medical Sciences for the word of thanks. Sir, over to you, sir.
Thank you so much. On behalf of the National Academy of Medical Sciences, it is my great privilege to thank both the eminent speakers for this evening for joining us and sharing their experience on tobacco control and cessation. I think all of us have learned from you. At least we have a better understanding of tobacco as a public health problem. So thank you so much for sharing your experiences and giving us a new understanding. And we look forward for your support and blessing to National Academy in future also. I will also like to thank all the participants, faculty members and the postgraduate students who have joined us and made this session interesting by asking questions. And once again, I will like to inform all the faculty members that the National Academy of Medical Sciences has extended the date for inviting application for fellowships and professor emeritus. So those of you who are willing to sort of apply for fellowship, you can do that online. And the last date has been extended to 25th of February. And those of you are already fellow of the academy, you can apply for emeritus professor. So these are two information for our faculty members. And once again, I would like to make an appeal that this is your own program. So kindly give your suggestion, comment for making this program better. Another information is for, again, faculty members from medical colleges. Our new president, Professor Digambar Bera sir, would like to talk to you or interact with you online through Zoom meeting on 12th of February from 3:30 to 4:30. So we have already sent you the letters, and also we have shared the details on the chat box. So please do join us and collaborate with the National Academy of Medical Sciences for various promotion of academic activities in your organization. For the students, again, the next session for this Navigate program is again very interesting session on pharmacovigilance, whereby you will be the eminent speaker in the country, Professor Y.K. Gupta. He was earlier head of department of AIIMS New Delhi and also the Dean Research. And he's also currently president of AIIMS Jammu. He has kindly consented to be with us. And this pharmacovigilance is very interesting topic for all of you, especially the postgraduate students, how we can ensure safety of drugs for the patient, as well as to minimize the side effects of drugs. So once again, I thank you all, and special thanks to Dr. Jaswant, who has been associated with us from the very beginning. And we are really grateful to you, Dr. Jaswant, for your support to this program. And you always make this program very interesting by moderating it. And again, at NAMS, we have our IT team, Mr. Ravi, who has been writing to you and also ensuring that the Zoom and transmission on YouTube is there. And we are going to put all this video recording as well as the PPT on our website. And all the students who have missed this session or may like to see it again, they can refer to the website. So once again, I would like to thank Mr. Ravi and Mr. Shivam, who have helped us from here. And once again, thank you all for being with us. And we look forward for your support and blessing in future. Thank you very much.
Thank you. Namaskar, everyone.
Yes, sir. So I think, yes, sir, with this, we can mark the closure of the session. And it was an amazing and interactive session. Thank you, sir.
Thank you, Dr. Jaswant. Thank you for facilitating.